Okay, thank you for introducing me. Good afternoon, ladies and gentlemen. I'm Yoon Kim. So I will introduce our first experience of percutaneous tricuspid valve in valve implantation using Pulsta valve in South Korea. So I will show you two cases. I have no disclosure. Case 1, a 27-year-old male patient who was initially diagnosed with a PAIVS with a moderate to severe RV hyperplasia. He underwent several times of open cardiac surgery because of moderate to severe RV hyperplasia, so his RV could not support biventricular circulation. And eventually, progression of TR and moderate PR and RA enlargement and hypertrophied RV trabeculation portion. So he underwent TVR with a Hancock 231 and PVR with a Hancock 227 and RV overhaul and AST creation for RV dysfunction. Unfortunately, both valvular degeneration developed so earlier than our expectation. So only 3 years after surgery, echo shows moderate TSR and moderate PR developed, and RA enlargement worsened again, and RV apex bulging and thinning with a dysfunction were noted. So our cardiac team discussed a lot of time for a treatment plan because of his surgical risk. So we conclude to perform percutaneous TVI and PTVI in this patient using Pulsta valve as off-label. So this is the information of the valve previously inserted into our patient. So Hancock 231 in tricuspid positions. So we conclude using Pulsta valve 28 diameter size and 33 millimeter length. RV angiogram shows moderate severe tricuspid regurgitation and PR. We marked the artery enlargement and poor RV function with the RV apex bulging and thinning wall thinning. So at first, we tried to procedure via right femoral vein and balloon interrogation with a 23 millimeter balloon for stability test was performed, but balloon position was not stable and easily slipping. And we also tried to using a different way, wire tension many ways, but failed, and making a wire loop like this, and tried, but also failed. So because of high risk of valve migration during procedures, we have to think of another approach. He underwent 1.5 ventricle repair. That means SVC and RA were not directly connected. So we could try to access through right internal jugular vein approach, so-called retrograde approach. So anyway, if the balloon interrogation is stable, so keep the position, we could try to implant the valve like this way. So we got right internal jugular vein access and made the wire loop like this, like directions. So luckily, it was stable in a tricuspid valve position. So nearest true internal diameter was 24, and the valve protrusion height was 17 millimeter. We plan to implant a Pulsta valve in this position for covering up full Hancock valves like this. So, and also we should change the valve loading way. This is conventionally, we loaded valve like this, distal part and proximal stent here. So inflow directions as it follow. So, but in this case, because of retrograde approach, we loaded the valve reverse. And so inverse inflow direction is as follows. First, Pulsta valve direct delivery catheter was advanced successfully on the tricuspid valve positions. And by rolling knob, and half of valve was expanded at this position. The valve adjusts the valve position by pulling back the whole system carefully until where we want it, the positions. And the valve is completely deployed at the target landing zone by pulling the slide. Hook block occurred. We have to check this before withdrawal of whole delivery systems, but easily released by changing wire tension and heartbeat, and the pullback delivery catheter safely. RV angiogram also shows good valve function and with a trivial TR and no paravalvular leakage. 1 month follow-up echo shows that also good valve function and no paravalvular leakage, although the AS descent flow was not clearly visible, but RA size was gradually decreased. Follow-up X-ray shows slightly decreased cardiac size, especially RA shadow. He presented doing well and feel better last DOA after procedures. So case 2, 39-year-old female patient who was diagnosed Epstein anomaly. She underwent 1.5 ventricle repair. So TVR with a C perimount magna 31 millimeter at the age of 27 years old. She presented with a palpitation and DOA since 2021 with a repeat progression of prostatic tricuspid valve failure. Pre-procedure echo noted severe TR and diffuse form and mild TS and RA enlargement into arterial septum deviated to the left and poor RV function. RV angiogram shows quite a lot tricuspid regurgitation. So we performed balloon interrogation using ZMAT 30 millimeter. Narrowest diameter was 28 to 29. So we planned that 28 millimeter size Pulsta valve like this. So we tried to pull the slider. This procedure via right femoral vein and using user loading techniques compared to case 1. So we try to pull the slider as hard as pull the slider like this. We positioned in half inches and positioned and pull back. We want to loading. And then we try to pull the slider as hard as we could for deploy the valve, but it couldn't work well. So during the procedures, the process of pulling the slider with more force, the valve is suddenly deployed like this. So I think it was we unintentionally pushed the delivery catheter like this. So, and there is no any other structure to block the catheter tip also. So it was developed. So at the same time in my mind, shit, OMG. So what should I do as assistant? First, I keep the wire firmly and go to OR to call the CS cardiac surgeon. So, but in flush, the device is get a proper position. So that is why is luckily the unreleased hook block. So we the operator pull back slightly and carefully a little bit pull back, and the valve was positioned right away. And release the hook block safely, firmly. And we have performed balloon angioplasty, tricuspid valve, because ZMAT 30 millimeter because of paravalvular leakage. So after that, we have performed RV angiogram shows good tricuspid valve function, but with reported noted mild paravalvular leakage and trivial TSR. So the procedure finished without any complications. Post-procedure 4-month follow-up echo shows that trivial TSR with a trivial to mild paravalvular leakage and slightly decreased RA size also. She presents less DOE. She prescribed this medication now. So in conclusion, PTVI using Pulsta valve on degenerated bioprosthetic is safe and feasible, and also a good alternative option to reduce surgery. So sometimes reverse loading technique can be a good strategy in repaired complex congenital heart disease patient. Thank you for listening.
Thank you. Is there any question and comment about this case?
Dr. Kim, I have the question that we don't have any choice at the moment in Korea to use the tracheal valve, the percutaneous tracheal valve implantation, other than Pulsta valve, because it is off-label and not would not be the reimbursed.
Yeah.
So the only I understand that the Pulsta is the only choice. However, if you have the choice among balloon expandable valve and the self-expandable valve, what would you choose?
I think sapien valve is the best because that valve reduces the paravalvular conformably. So
radial force is
radial force.
the not enough to prevent the
also
paravalvular
incisable.
leakage. Yeah, and also maybe the implantation, the technique may be tricky because you don't like jump,
Yeah.
the word jump, but it's actually a little bit jump. So it may be technically tricky. So I wanted to ask about that. Yeah.
Do you know about the mid-term or long-term outcomes for this practice?
So honestly, we don't know about this valve because Pulsta valve developed only 5 or 7 years old, 7 years. So we don't know. But other percutaneous valves, 10-year reintervention rate is not bad. I know. The most of caused percutaneous valve degeneration causes thrombosis. So that's why we use warfarin, anticoagulation, and antiplatelet agents. So that improves longer duration. So I don't know exactly, but other valves present not bad outcome.
As I presented yesterday about Melody and Sapien 2011, 15 cases, and then 2016 Vivid Registry 152 cases, kind of 5 or 10-year survival is 99% so far. And as you mentioned about endocarditis, in addition to you. So far, it is kind of promising. But Pulsta, we have no data, but this Dr. Kim's data is pioneer in our country and then in the world. So we will look at together, I think.
However, infective endocarditis, the pressure, the high-speed jet is the prerequisite. So if the valve doesn't develop the regurgitation, predominant regurgitation, the concern about the infective endocarditis may be less.
Low, yes, correct. And the one procedure-related death is hemopericardium, so we need to be aware of those.
My concern on the Pulsta valve in tricuspid position is that what do you think is the second case? The valve itself repositioned automatically. So what do you think is the reason of self-repositioning?
You said means why the cause to move the properly? That's why on release the hook block. So this case operator is Sejong. So Sejong gently pull back a little bit. So the valve move the proper positions. That is very locked. So if the hook block release all the hook blocks, maybe we will go to OR. Maybe.
Where is Dr. Jung?
Dr. Jung.
Yeah, did you hook the strut and pulled back?
Actually, yeah, because PTVI is different to some PTVI because pulmonary valve implantation is we do in tubular structure, but in PTVI is a kind of cavity. So the the landing zone is very difficult, and so
Yeah,
at
yeah,
the
yeah.
time
It is the oblique.
jumping is very in the self-expandable stent. We can pre-contaminate the jumping out. So at the time the stent slight jumping out, and actually in PPVI I use the hook block the torsion make a tension or tension release to hook block release, but at that time I didn't release the hook block, and then and I keep the wire and keep the hook block position, and then slightly drag into the fractional portion. At that time, slightly the stent slightly milking out then.
Yeah, then maybe the stent, the valve maybe migrate further with the little tension. We should be careful, yeah?
Thank you for your nice presentation, and I would like to propose something. For the first case, you proposed internal jugular approach retrogradely. How about the VV loop? Make a internal jugular and femoral loop, and then proceed from the femoral vein approach normally.
Yeah, I thought too, because we via right internal jugular vein and to make the wire loop into the femoral vein, we use gooseneck wire and firmly tightened the wire rod. So after that, I thought to finish the after procedures, we have to do samely. So right femoral vein and right jugular vein, and jugular vein is make a tension. I think it is a possible maybe.
Actually
Yeah,
loop,
I agree
right?
with you.
Okay.
Yeah.
In conventional tricuspid valve intervention, you use the right femoral vein normally and successfully, but I wonder, how about internal jugular approach? The external jugular approach is better than, you think is better than the femoral vein approach?
Yeah, because of APCIS, right? But in this case, this person is 1.5 ventricle repair, so we cannot make the
No,
right.
I would like to say in general concept.
General concept, yes, right jugular vein is the more better axis. Yeah, I agree with that. The report said that. Okay, that too.